Awesome. So I'm so glad to be on here with everyone. And this training is really geared towards clinical staff. Providers are obviously welcome, but it really is geared towards clinic staff to talk about this new movement that's happening across the state of California that is being sponsored by the Office of our Surgeon General and the Department of Healthcare Services around universal screening for ACEs and trauma. So we have so many different learning objectives, and I'm very excited to share them with everyone. And as we go along, if people have questions, please enter them in the chat. And as much as possible, I will stop for questions. And my two amazing coworkers, Artemisia Jackson, who's the program manager for our navigation program, and Marina Franco, who is one of our navigators, are also on the call, and so they can both help to field questions. Artanesha, do you want to introduce yourself really quickly?
Good morning, everyone. My name is Artemisia Jackson. I'm a clinical social worker and program manager for Find Connect. In a really quick announcement, I know there was an issue with registration, and so while we're on the call, if people could just take a moment to use the link in the chat to make sure that we're registered so we can collect all the information we need. Thank you so much.
And Marina, do you want to introduce yourself?
Sure. Hi, everyone. My name is Marina, and I'm a Find Connect navigator. I'm working with Dr. Dayna Long and Artemisia Jackson on this project with ACES Aware. So if you have any questions, please put them in the chat, and I'll do my best to answer your questions. And like Artemisia said, please register for the event so that we can have your information for any follow-up that's needed. And I will also put the evaluation link into the chat towards the end of the presentation as well. And enjoy.
Thank you so much to both of you. So as we go through these learning objectives, I really want our main vision and goal to be how we are supporting each of you in your clinics as part of CHCN in order to screen our patients that come into our clinical settings for ACEs and trauma. And I understand that it is those of us that are on the front lines that are interacting with community and supporting community in a really strength-based fashion in order to make sure that we are reducing exposure to harm to our kids and really promoting the amazing strength and beauty that we see in all of our communities. And so the learning objectives for today are to define adverse childhood experiences, their prevalence, the health disparities data, to talk about what toxic stress is and how this toxic stress can really get underneath our skin and affect our biology. If people could put their thumbs up on their pictures if they've heard about ACEs, that will really help me gauge how deep to go into this subject, because I want to make sure I tailor it to everybody. Thank you, Ashley, for the thumbs up. I really appreciate it. Thank you, Erica. Thank you, Mia. Thank you, Melissa. Awesome. And then we want to talk about how are our community clinics really integrating ACEs screening into their clinical workflows using these principles of being trauma informed. We want to make sure that we are focusing on how to assess risk within our kids, and that involves all of us. It involves the entire healthcare team. And then to talk about how do we draw down on the payments from Medi-Cal in order to support screening and to really understand for each of our individual clinics. And, you know, I know that Bay Area Community Health, I know that Lifelong, I know that La Clinica, I know that Elmhurst School-Based Health Center, like all of you guys are here on the call, and it's going to look slightly different in your clinic. And so the part of the objectives are to give you guys information so that you can go back to your own implementation teams within your clinical setting in order to say, okay, so we're screening for ACEs. What is our clinic response? And I really hope that we can come out of this session with each of you in your own individual clinics to understand this is how we screen and this is what our clinical response is. And it is a journey and a process, and we all just need to start. ACES Aware, and this is a state initiative, has the mission to change and save lives by helping providers and clinical staff to really understand the importance of screening for ACEs and training our clinical staff to respond with trauma-informed care to mitigate the health impacts of toxic stress. This is part of this big, bold call to action across the state of California to really cut ACEs and toxic stress exposure in half by 1 generation. And in order to do this, it's going to take all of us working together. And I can tell you that those of you that are clinicians or referral coordinators or social workers or community members have a huge role to play in making sure that this call to action happens. I'm going to briefly go over what ACEs are. I know that the vast majority of you already know, so this is just a reminder that the ACEs are very specific categories of questions that are in 10 categories and 3 domains that came out of a landmark study that occurred in the mid-1990s in San Diego, and it was sponsored by the Center for Disease Control and Kaiser Permanente. That study looked at over 17,000 Kaiser members who were adults, and it asked them to reflect retrospectively on experiences that they had in their life prior to the age of 18. And the results of that study that blew everybody's mind were that there is a dose-dependent relationship between exposure to adversity and poor health outcomes. And these poor health outcomes are across the spectrum. They're physical health outcomes, behavioral health outcomes, and mental health outcomes. These categories of abuse include, or categories of ACEs, I should say, include 3 main domains, and that's abuse, and that's physical, emotional, or sexual abuse. That's neglect, which is physical or emotional. And there's a broad category of household challenges. And those household challenges include growing up with a household member who's incarcerated, having mental health concerns within the caregiver, the primary caregiver of the household, having a caregiver who has substance dependence, having a caregiver that's absent due to separation or divorce, or intimate partner violence. So graphically, what we can see are these are the 10 categories and 3 domains of adverse childhood experiences that were reported in that initial ACEs study, sponsored by the Center for Disease Control and Kaiser Permanente. And what we have learned is that children who are experiencing currently ACEs, the higher the ACE score, the more symptomatology and associated health conditions, such that children, even very young children who have 1 or more ACE, are more likely to have somatic complaints or concerns such as stomach aches, and that children who experience 1 or more ACE are also more likely to have poor perceived health by their caregiver. And this data came from a study that my colleagues and I recently published, where we enrolled about 555 of our kids who come to our federally qualified health center, and we asked their adult caregivers to take an ACEs screen. And then we looked at the scores of the children and connected it to somatic complaints like headaches or stomach aches, as well as to diagnoses of illnesses and the parental perception of health. And these are young children. The average age was 5 to 6 years of age. We also know that children who have 4 or more ACEs are 2 to 3 times more likely to have asthma. And the more ACEs that a child has, the more poorly controlled their asthma symptoms are, such as there's more cough, there's more wheezing, there's more nighttime awakening, there's more missed school secondary to asthma symptomatology. We also demonstrated that children who experienced 4 or more ACEs had 33 times more likelihood to have learning and behavioral issues. We asked caregivers to work with their children in order to complete screens that looked at executive functioning of a child, their ability to focus, their ability to attend, their ability to use their prefrontal cortex in order to show up and be ready to learn in school. And it is statistically significant and super concerning that for children, if they have 4 or more ACEs, 33 times more likely to have learning and behavioral concerns, right? What we are seeing here is really a crisis of the amount of trauma that our children are being exposed to. And then when those children grow up and become adults who experience 4 or more ACEs prior to the age of 18 are over 2 times more likely to have heart disease. This includes strokes, high blood pressure, heart attacks, 2 times more likely to be diagnosed with cancer, 3 times more likely to be diagnosed with respiratory illnesses, whether it is emphysema or COPD, almost 5 times more likely to have depression, 10 times more likely to have problematic drug use, 37 times more likely to attempt suicide, and have 9 out of 10 of the leading causes of death in the United States if they have an ACE score of 4 or more. When we talk about the root cause of illness, a lot of it happens because of what we experience and the stressors that are in our lives prior to the age of 18. And it is the accumulation of those stressors over time that lead to poor health. Data from 2017 from the California Department of Public Health, Injury and Violence Prevention suggests that when they did a survey that Californians who experienced at least 1 ACE are approximately 62% of our population, right? 62% of Californians up to 2017 had experienced 1 ACE in their life. And 16% of Californians have experienced 4 or more ACEs. This data is pre-COVID data. And we also know that experiences of trauma and adversity are amplified for our Black and Brown communities that aren't necessarily represented in this data sample. The reason why we care is because stressors, these events, lead to different types of stress. And I want to talk about 3 different types of stress that we all experience. The first type of stress is what we call positive stress, right? And positive stress is brief stress that causes brief elevation in our heart rate and our blood pressure, mild elevation in the release of stress hormones. And when we think about stress hormones, we think about adrenaline, noradrenaline, and cortisol. It is brief and temporary. And so positive stress is that it might be that when school starts in the fall, kids are a little nervous about going back to school. It might be that you're trying out for a new soccer team. It might be that you have to take a test. Positive stress is brief stress that is temporary. And when the stressful event is over, you go back to your baseline. We call that baseline homeostasis, right? Back to balance. Tolerable stress is more severe stress. So tolerable stress is serious stress that is a temporary response to a stressor. You are buffered by safe, stable, nurturing relationships. And when that stress is over, you again go back to homeostasis. And so tolerable stress, it elevates the adrenaline, the norepinephrine, the cortisol. But when that stress is over, you're surrounded by the supporting love of your family and community, and you can go back to baseline. And so tolerable stress might be that there's a big move. It might be that there was a grandparent who was sick and that grandparent passed away. When we are referring to ACEs, we are referring to the development of a toxic stress physiology as a consequence of long-term exposure to a stress response that accumulates over time.
Dr. Long, you're unmuted. You're muted.
Thank you. I'm not sure how that happened. Thank you for telling me. So toxic stress is more prolonged stress that involves activation of our stress response in the absence of safe, stable, nurturing relationships. And so let's say that I'm walking in the woods and all of a sudden there is a bear that comes out and is ready to eat me, right? So at that point, my stress response is activated. When it is activated, I release adrenaline, I release cortisol, I release norepinephrine into my system, and that allows me to do one of three things, right? It allows me to fight that bear, to flight, to run from that bear, or to freeze and to hide so that I can pretend like the bear cannot see me. This stress response is amazingly adaptive to fighting off bears. The problem is when that bear comes home every single night, that stress response that allows me to fight, flight, or freeze is constantly activated. And then over time, it causes weathering, it wears me down, it becomes maladaptive. And I am constantly hypervigilant, looking out for that bear because I don't feel like I have that safe, stable, buffering environment and relationships. This is what toxic stress does. And so another definition of toxic stress is that toxic stress is when you have high doses of accumulated adversity, right? Those ACEs, those stressors that are experienced during critical and sensitive periods of early life development without having buffering protection of safe, stable, nurturing relationships and environments. And this toxic stress response, it gets underneath our skin and it can lead to long-term disruptions of brain development, of the immune system, of the hormonal system, and our genetic regulatory system. And this is what we refer to as toxic stress. If there are questions about that, please put them in the chat. It's really important for folks to understand that the reason why we are screening for ACEs is to identify children who are at risk for a toxic stress physiology in order to prevent, heal, and treat the long-term health consequences of exposure to that adversity. What the science does tell us is that providing safe, stable, and nurturing relationships and environments for children are the three critical qualities that allow for buffering of the stress response. And so I want to define what we mean when we say safe, stable, and nurturing, because these are the essential agreements of authentic and intentional relationships and environments. And honestly, in many of our communities, particularly again in Black and Brown communities, we have a long way to go before we can create safe and stable, nurturing environments and relationships. And that is exactly what we want to do. And it's exactly why we all are working together in order to universally screen children for trauma within our clinics and do this within a resilient framework. So when I say safety, I mean the extent to which a child is free from fear and secure from physical or psychological harm within our social and physical environments. Excuse me. When I say stability, it really is the degree of predictability and consistency in a child's social, emotional, and physical environment. And then nurturing is the extent to which our children's needs are sensitively and consistently met. The reason why we screen for ACEs is because we want to identify children who are at risk for developing toxic stress physiology. And honestly, there's so much variation within our individual physiology that we have to intervene early in order to be able to identify those children who might have symptomatology. And so you're going to have children who experience ACEs who are completely without symptoms and have very healthy, long lives and good health outcomes. And then you have children who experience ACEs who have some disruption within their neuroendocrine and immune system. You don't see obvious symptomatology. And yet, as they grow into adulthood, they will develop, whether it's obesity, diabetes, hypertension, cancer, that leads to an earlier death. We also have this group of children who experience ACEs, who have disruptions of their neuroendocrine and immune function, who do have social, emotional, and cognitive impairment, who adopt health risk behaviors, and then develop early disease, disability, and death. We screen for ACEs in order to ensure that we can prevent and treat the ramifications of this toxic stress physiology early on in life. And so what we know is that children who experience early life adversity, there is a balance. There's a balance between the protective factors, right? All the love, the nurturing, the stability that the relationships and environment provides. Children have predisposing, genetic, inherited vulnerabilities that when it balances out, right, that the scales can tip. And when the scales tip, you can get chronic dysregulation of our endocrine, our neuro, and our immune systems that has clinical implications. One of the most fascinating fields of science is epigenetics. And what epigenetics tells us is that although you're not changing the genetic code in and of itself, moments of time, stressful events over time can change the way that that genetic code is read. And all of a sudden you are coding for asthma or cancer or diabetes. And then these switches that flip on from epigenetic changes can then be inherited across generations, right? And the clinical implications span our endocrine system. So this is our metabolics, our coding for things like diabetes within families, our reproductive systems, our immune systems, cardiovascular systems. Going way back to 2013-14, a group of my researchers, including Dr. Brooke Harris, got together and started to think about how can we prevent these switches from flipping, right? How do we actually screen children early on in life? How do we screen adults in order to prevent intergenerational transmission? What does that screening tool look like? Because the initial ACEs screening tool was a retrospective tool, right? It asked adults to reflect on what happened in childhood, but how can we actually screen children early on before the poor health outcomes develop? And so we wanted to create this tool. We also wanted to look at what we call biomarkers. And so biomarkers are, for instance, if you have diabetes, you check your hemoglobin A1C. Your hemoglobin A1C tells you how much sugar is linked up and connected to your red blood cells, and that gives you an indication of your diabetes control. We wanted to see what a panel of biomarkers look like for toxic stress physiology. We also wanted to look at clinical diagnoses that are associated with the accumulation of adversity. And we wanted to know, how do we respond? What are interventions that are evidence-based that can actually mitigate the harmful effects of exposure to trauma? And so I'm going to tell you a little bit more about each of these key objectives from our research study. The first objective was to create a prospective pediatric ACEs screening tool. And we call that tool PEARLS, which stands for Pediatric ACEs and Related Life Events Screen. This PEARLS tool, it is true to the original 3 domains and 10 categories of the initial ACEs study. We wanted to make sure that we could look at population level data. And what we do know is that we do have population level data for that initial ACEs study. And so we wanted to be true to that. We also recognize that there are other related life events. Many people refer to these as social determinants of health that have been shown to lead to poor health outcomes, but not at the same population level as the initial ACEs study. And so that initial fourth domain is, it includes questions about food insecurity, about housing instability, about racism and discrimination, and about violence outside of the home, including police violence and bullying. So the Pearls tool has a part 1, which is the initial ACEs question, and a part 2, which are these additional questions. And if you guys could just put a thumbs up if you've seen the Pearls tool, and I'm hoping that you have. And I'm going to ask Marina to put a link to the Pearls tool on the ACES Aware website into the chat so everybody can pull it up and look at it. I want to reiterate that this fourth domain, these questions that we often refer to as social determinants of health, are in fact associated with poor health outcomes, but not to the same extent or with the same strength as the initial ACEs study. And so when I say related life events or social determinants of health, the way that I define that is that social determinants of health are really conditions in our environment in which people live, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. The social determinants of health are education, employment, health systems, services, housing, income, wealth, the physical environment, public safety, the social environment, and transportation. When I refer to this fourth domain, I had alluded to the fact that discrimination and racism is a related life event. And what we do know is that racism has been linked to birth disparities, that racism has been linked to mental health issues, and that racism in and of itself can get underneath our skin and it affects us on a biologic cellular level. I want to refer you guys to the American Academy of Pediatrics policy statement about the impact of racism and on adolescent health. The citation is here on the slide. Racism causes structural inequities and poor health outcomes across the lifespan. And we know that racism, it affects birth outcomes. And so for Black women, we know that we have a 3 times more likelihood to die from a pregnancy-related cause. Sadly, there was a fantastic report that was recently published in 2020 that said that Black babies are 3 times more likely than white babies to die when cared for by white doctors. Black children are 5 times more likely to be admitted to the hospital for asthma. Black children are 2.5 times less likely to read at grade proficiency. Black adults are almost 2 times more likely to be unemployed, 7 times more likely to be incarcerated, and 2 times more likely to live in poverty. This science, this data is disheartening, and we have to understand that racism and discrimination impacts the health of Black people. And so that when we think about African Americans and poor health outcomes, to recognize that African Americans are more likely to die at earlier ages from all causes, whether it's blood pressure, diabetes, or strokes. There's a quote from Dr. Ken Hardy, who's a professor at Drexel University, that really speaks to that racial oppression is a traumatic form of interpersonal violence, which can lacerate the spirit, scar the soul, and puncture the psyche. This is the Pearls tool. And part 1 of the Pearls tool are these initial questions. These are the original ACEs questions. There are 10 of them. They're divided up into 3 categories. And then part 2 of the Pearls tool includes these other related life events questions. I was just referring to experiences of discrimination and racism to say how racism and discrimination can get underneath our skin, but there also is evidence that concerns about food insecurity or violence in communities, as well as housing instability, can also get underneath our skin, and if accumulated with other adversities, can lead to poor health outcomes. I'm going to pause for a minute just to give folks a chance to look at the tool. I recognize the importance of what we're asking all of you all to do, since you guys are on the front lines, that we are asking that this tool be given out to children annually from 1 year of life up to age 21. And then above 21 through adulthood, there is the initial ACES questionnaire that can be used for adults. We want to be able to identify children who are at risk early on in life in order to prevent poor health outcomes from happening. And in order to do that, we need to universally in an unbiased fashion screen children and then respond to the screens. I'm the principal investigator with my colleagues at UCSF and the Center for Youth Wellness on the creation of this tool. And the gold standard within the medical field is to do a randomized controlled trial, right? Which is where you then gather evidence in order to inform clinical practice. And so we use this tool at our Claremont Clinic, which is our federally qualified health center. We enroll children from 3 months up to the 12th birthday. The average age, as I said, was 5 to 6 years of age. And using that tool, we found prevalence rates for adversity within our community, and we all see the same community here, right? We are all within Alameda County, and although there are specifics within each of our clinics, we are all safety nets. And what we found is that 76% of our caregivers who took the Pearl screen for their child endorsed at least one adversity, and almost 40% reported that children average age 5 to 6 years old already had 4 or more adversities. This data on our children is dramatically different from the data that I had just showed prior that for the state of California. And to remind you what that California data said is it suggested that 62% of Californians had at least one adversity and 16% had 4 or more. That was using the initial ACES screen. When we use the Pearl screen on our families, we can see that 40% of our 5-year-olds already had at least 4 or more adversities. The higher the Pearl scores, the higher was the association with poor perceived general child health, decreased global executive functioning, and an increased odds for having asthma and stomach aches. This is the vast majority of our kids. If you want to look at the percentages of pearls that are endorsed by our children, you can see here, these are the prevalence rates for the children that we enrolled in the study. And I just want to point your attention to the high levels of caregiver mental illness in our community. And this is pre-COVID data. We all know that COVID exacerbated disparities and inequities, right? We look at high levels of domestic violence. We look at high levels of neighborhood violence, housing instability, food insecurity. And of our 5 to 6 year olds, 15% of caregivers endorsed that their child had already experienced discrimination. We also wanted to create correlations between having those original ACEs that I referred to, and these original ACEs are abuse, neglect, and household challenges, and these related life events, these social determinants of health, right? Housing instability, food insecurity, community violence, exposure to racism and discrimination. And what we found is that if you look at, for instance, neighborhood violence, right, you see that there is a 90.4 probability of then having an initial ACE and almost a 75% probability of then having a second initial ACE. And so these related life events and the initial ACEs are highly correlated with one another, such that if you have a related life event, there's a very high probability that you have 1 or more ACEs. The first screener that I showed you is the child screener, and that is for children between the ages of 1 up to 12. And then for 12 and up, we did create an adolescent screener. And the difference between the child and the adolescent screener is an additional 2 questions. If you look at part 2, you'll see that there are 2 additional questions, 8 and 9. And so Question number 8 is has that adolescent actually ever been detained, arrested, or incarcerated? And then question number 9 is, has that adolescent ever experienced verbal or physical abuse or threats from a romantic partner? And then this is the adult questionnaire. So if you are a family practice and you are seeing adults, this is the recommended questionnaire. There also is some really fascinating and innovative work that's happening, for instance, in Oregon, where for children up to the age of 2, they actually are asking the parents to take the questionnaire for themselves because they found a high correlation between parental ACEs and child health outcomes. There are many different versions and formats of the screen. And so there are 4 different versions. There's the child questionnaire, which is for 0 up to the 12th birthday. And then there's a teen questionnaire. And that teen questionnaire is a self-report questionnaire. And there also is a teen questionnaire for the caregiver themselves to fill out for the teens. And this is from 12 to 21. Within your clinical setting, and this is where each clinic is unique and your implementation team will decide which one to use. You either can have the teen simply fill out the questionnaire for themselves, or if for any reason that teen is unable or doesn't understand, you can actually have then the caregiver fill it out for the teen, or you can have the caregiver and the teen fill it out and then compare the results. There are also 3 different formats, and so I just want to review these with you. And so if you look at this questionnaire is what we call a de-identified questionnaire. When I say de-identified, you look at part 1 and you see that you do not ask the family to put a check mark by each individual question. Rather, there's just the total score, right? This is so that you get an aggregated total score, but you don't know which individual question is positive. Part 2 is an example of a questionnaire that is what we refer to as identified. And so there's a check mark next to each individual question. The ultimate decision of what type of questionnaire is, again, a decision that you will make within your clinical setting. Many clinics want to do the identified format so that they can actually respond to individual concerns. Other clinics want to do it in a de-identified format. And by doing it de-identified, they just know a total score. And that score helps them to decide risk level for a child for developing toxic stress physiology. If we were in a room together, I would ask for a show of hands about which format your clinic is going to use. You can put it in the chat if you guys know, or if it's still a question, I would love to know what you guys land on. And then the screen itself is, I'm so pleased to say, it's in 17 different languages. There's a link here on the slides. And again, Marina, maybe you can put this link into the chat where you can see all the different languages that the tool has been translated into. And the way that the tool is distributed is we give it out on paper. In our clinic. It also can be put in your MyChart or your EMR portal. You can do a screen share if you're doing telehealth. And then you also can incorporate it onto your website if you want to direct patients there. So who do you screen and at what frequency? I cannot stress the importance of recognizing unconscious bias. Right? And so it is essential that we have protocols in order to make it so that we are not screening patients in a biased fashion. So patients should be screened within pediatrics annually without selection bias, right? And so for children under the age of, for adolescents and children under the age of 21, you screen annually. And you can draw down on payments annually in order to get paid for screening. And for adults between the age 21 to 64, it's permitted once in their lifetime. Why do we screen? There are so many reasons that I have listed out for. But to me, we screen because it's the right thing to do. We screen because we want to make sure that we are protecting and supporting the health of their children. But we also know that screening improves the efficacy and efficiency of our healthcare system by getting to the root cause of many illness, by understanding what's triggering that poor asthma, or what's triggering that diabetes, or why is it that this adolescent is having depression and anxiety, right? We screen because we want to be able to support individuals and families and their well-being. We want to reduce healthcare costs. If we can prevent the asthma from being very poorly controlled, then we could prevent the child from getting admitted 10 times to the hospital. That reduces healthcare costs, but ultimately we want to be able to improve the health of that child. We have to be able to normalize and have conversations about trauma. We are amazingly resilient, and part of resiliency is being able to be with our communities and our families and talk about the hard things, to talk about our experiences of racism or discrimination, to talk about violence in our community, and to make sure that we are talking about it and then doing something about it. So the National Academy of Science, Engineering, and Medicine came out with a statement, which is screening for trauma and adversity early in life to increase the likelihood of early detection. That we should include creating rapid response and referral systems. We can quickly bring protective resources to bear when early life adversities are detected through the coordination of cross-sector expertise. Right. And when we screen adults, we screen to improve the management of their ACE-associated health conditions, but also to prevent vertical transmission of ACEs and toxic stress to the next generation. Dr. Alicia Lieberman has had this amazing statement that I wrote down, which is talking about trauma opens the door to healing. People want to be seen, known, and understood. Sometimes we take the longer, short road. Having hard conversations is in itself therapeutic. If we actually want to promote health, we need to actually see one another and understand who we are and really take this road together so that we actually can get to a place of healing. So there are key elements of the clinical workflow, and it is the goal of Artanesha and I to work with each and every one of you in order to make sure that we are getting all 7 of these key elements of the workflow implemented within your clinics. And so the first element is deciding who can administer the tool, making sure that the tool itself is completed. I'm going to talk to you about how to review and score the tool. I'm going to show you these algorithms in order to determine what the response is, to make sure that each of you guys in your clinic is creating a follow-up plan, that you know how to document and track it, and that you know how to bill it. So this is the pediatric ACEs screening clinical flow. And so it's really important. And again, if we were in person, we would be doing this in breakout rooms. And so what I suggest is that each of you get this algorithm and then you fill in the name of the staff member who's going to be doing this work within your clinic. And so you assign a registration or a clinical staff member who can review the patient record prior to the patient coming in to see if this is a visit where you would be giving the Pearl screen. And you guys already do this for all the other screeners that you have, whether it's the ASQ or the ACT screen for patients with asthma or the MCHAT. And so annually for Pearls, that staff member then lets the family know that we are asking families these questions because we want to make sure that your child is as healthy as possible. Our clinic has tools and resources in order to help to support you and your family. And then that registration staff then gives that screen to either the patient or the parent, right? When the screen is complete, they hand it off to the clinician. And that clinician might be the MD, the MP, or the medical assistant. That clinician then makes sure that they enter the Pearl screen into the electronic medical record. The provider that is seeing the patient then reviews the screen. They review it with the family. They then document that what the score was in the EMR. They document the billing codes. And then with the family, they create a treatment plan and follow up, and they put that in the clinic note. And then the next time the patient comes in, that provider then will review that note they wrote and the follow-up plan. The way that we score the Pearl screen, and this is really important for that registration person, that medical assistant, the LVN, whoever it is that's entering the screen into the EMR, right? And so low risk is if the score is 0. And if the score is 0, we provide education, anticipatory guidance on ACEs and toxic stress and buffering factors, right? This is the job of the clinician that then is seeing the family. If the score is a 1 to 3, you have to think, is it associated with other health conditions? And I'm going to show you what those health conditions are. If there's no associated health condition, then the provider then provides education, anticipatory guidance on ACEs, toxic stress, and buffering factors. A high score is considered anything above a 1 if there are associated health conditions, or a 4 or more, regardless of if there are associated health conditions. And if that's the case, then the provider provides all the education, they talk about buffering, but they also make sure that they are linking the family to resources and referrals and interventions as appropriate. If the score is unknown, we still recommend that the provider provides education, because the score can be unknown because the family didn't feel comfortable completing the screen, or there wasn't enough time to complete the screen, and we still want to make sure that we are providing primary and secondary prevention. So these ACE-associated health conditions are symptomatology or diagnoses that have empiric evidence to be linked to exposure to ACEs and then poor health outcomes. I do want to stress that while there is a relationship between ACEs and mental health outcomes, the single greatest driver of ACE-associated healthcare costs is actually cardiovascular disease, heart attacks, and strokes. And so when we look at the leading causes of death, these are the 10 leading causes. There are high odds ratios of if you have ACEs, having one of the leading causes of death in the United States, with cardiovascular disease being the greatest driver. So there's a 220% chance of having cardiovascular disease if you have an ACE score of 4 or more. That's like no joke, right? And if we can intervene early, we can prevent that devastating outcome. And so these are the ACE-associated health conditions for pediatrics. And so these are health conditions or symptoms that have a high odds ratio for being diagnosed with if you have an ACE score. And so those ACE-associated health conditions include asthma and allergies, to being overweight and obese, to having developmental delays, to being diagnosed with ADHD, to having suicidal ideations and attempts. There are also ACE-associated health conditions for adults, everything from cardiovascular disease to arthritis to anxiety to PTSD. And you can see the odds ratios for having these health conditions based upon an ACE score. The role of all of us as primary care clinicians is really to learn the science of ACEs and toxic stress, to make sure that we're providing trauma-informed care, and then to help our patients understand the role of toxic stress within their lives, to help patients to identify strengths and coping factors, and to really jointly co-create a treatment plan, such that if you're treating pediatric asthma that is very poorly controlled, to understand the underlying stress that might be adding to that poorly controlled asthma. And so you still will be providing asthma education about controller medications, about quick relief medications, but you also will be talking about managing that child's stress and providing a safe, stable, supportive environment for that child. I know that we have just a couple more minutes, and so I want to just skip over these next couple slides, because a lot of them I think that you guys have talked about a lot, right? The first is making sure that we are always applying these trauma-informed principles of having authentic, intentional relationships with each other as staff, but also with our community. about always making sure that we're validating the existing strength and protective factors of our patients. And so when we administer the Pearl screen to say, yes, these are very hard circumstances that happen to our children, and you are a good parent, you're doing a good job, we are here with you, we have resources, and that the biggest single factor that will help your child be healthy is the relationship that your child has with you. So when we refer to this anticipatory guidance or what to say, right, we use this acronym that we call NOTE. And in this acronym, the N stands for relationships. It's all about relationships and strengths. And so make sure that you notice that relationship and you comment on it. I notice that every time you read to Susie, she lights up, she smiles. That bond that you guys create together is going to help her get through the hard times, and it's going to help you delight in one another during the good times, right? We offer the science to say that children experience stress, that stress gets underneath our skins, and it can affect their hearts, their minds, and their bodies. That we do have tools and resources in this clinic in order to help Susie be as healthy as possible. And the E for empowering. You are a good parent. I am here for you. Parenting is hard and you're doing a good job. We always want to make sure that we're focused on these protective factors, on supporting the caregiver, on talking about emotional connection, on making sure that the parent understands parenting and child development as much as possible to address unmet basic needs. And that's why Alejandra and Marina and Artanesha are here today, because we do want to be able to help you in creating networks of care and referral systems to community-based resources. To really focus on the social emotional well-being of children and to help adults create that safe, stable, and nurturing environment. I'm going to skip over to this slide, and then I'm going to pause for questions. And so when we think about evidence-based strategies for toxic stress regulation, these are 7 stress-busting strategies that are put forth by the Office of Surgeon General. The first is that we always want to focus on relationships. We focus on quality sleep and sleep routines, balanced nutrition, understanding that food is medicine, making sure our families have access to food, really talking a lot about physical activity, which might include going for walks or turning on an exercise video or just dancing around the house for 20 minutes a day. Mindfulness practices, and this might be spirituality, it might be meditation. Getting access to nature. Studies have shown that taking walks outside or looking upon nature help to decrease cortisol, help to decrease blood pressure and heart rate. And then making sure that we are attending to the mental health of our patients and community. One of the great things that we're hoping to be able to offer to you is access to our Find Connect platform that can help with resourcing needs and referrals and care coordination. And some of the resources that we have are built around food insecurity, housing instability, the need for activities for our young people, help with utilities, medical legal concerns, childcare, especially during this era of remote learning, which I'm hoping is over soon, getting kids signed up for internet, emails, and devices. So I'm actually going to stop sharing and I'm going to pause, and I'm going to see if there's any questions. All right, I believe that we have till 11:30, and so we have about 1 more minute. I am so excited to work with all of you in your clinics on implementing Pearl screening and the response to it. And Artanesha and Marina and I are here for more training, for one-on-ones with all of you. We also are offering each of your clinics access to our Find Connect platform, which I believe you've been working with Artanesha on doing a demo of in order to help with resources and connection.
Dayna, I just want to say that we do have until noon. So if you want to finish the slides, feel free to do so.
Okay, great. Awesome. Are there any questions that any of you guys have? All right. I have a couple more slides to go over with you. And so we talk a lot about primary care-based mental health interventions, and the interventions, this is the response part of ACES screening, right? Those interventions are, much of it is this notion of anticipatory guidance, and anticipatory guidance is what the education, the information, the preventative work that we do with families, and that in and of itself is therapeutic. And so whenever I administer a Pearl screen, you do this anticipatory guidance around noticing the relationships and commenting on it, offering the science, talking about resources and tools, and then really empowering families. Many clinics such as ours are also now doing group visits for resiliency. And these are small dyadic clinics for parents and their children. Usually it's 2 to 3 parents and their kids, where we work on things like mindfulness, on self-regulation and co-regulation. If any of you are interested in the curriculum around resiliency clinics, I'm happy to pass on the contact for the clinic director, Dr. Joanne Jung, who also did some of this work at Asian Health Services. Some clinics have behavioral health integration, others have social workers. Ideally, we'd have both, but I know that that's not the case all the time. Children's recently started the psychiatry portal, where you can get real-time one-on-one consultation with our Department of Psychiatry. And then there's a ton of community-based mental health resources that are on the Find Connect platform that we can refer families to. I acknowledge that although we have many of those mental health resources, it is not enough. And oftentimes this work happens within primary care clinics. This work is really hard. And we want to make sure that we are responding to community, but oftentimes there's a lot of trauma-informed work that needs to happen within ourselves and with our clinics, right? There are politics and structural issues that are often inherent in staffing, especially within a lot of the clinics that I have been working in. And so we recently have been working with a group called Dovetail Learning on staff tools that have helped with our ability to work together and to collaborate. And so they have these 3 principles. The first is on centering, right? And centering is, how do I get myself into balance? How do I focus on my own personal resilience? And part of that is noticing myself and my reaction, making sure that I am contributing to the group intentionally, making sure that I am letting things go, that I am forgiving myself, that I'm trying to bring my best self to the work. Connecting is about relational resilience, right? And connecting is, how do we actually work together within our clinic, right? How are we communicating? How are we talking about equity within our clinical staff? And then the outer circle is about sort of collaborating, right? Like, how are we moving towards having a uniform goal of universally screening every single one of our patients for every well check annually? This expectation that we can be immersed in suffering and loss daily and not be touched by it is as unrealistic as expecting to be able to walk through water without getting wet. I just want to acknowledge that as we are screening, it often can trigger vicarious trauma within our staff, and that we need to attend to caring for our staff as we are also caring for our patients and community. I do see a question about suggestions for administering pearls or ACEs during a telehealth visit. I think this is a great question. Within our clinic on Claremont Avenue in Oakland, we are only doing the pearl screen in person. Many clinics are moving towards having a lot more in-person visits than we were during the beginning of the pandemic. I do know that there are some clinics in Alameda County and LA County that are administering the tool during telehealth. And what I've heard from those clinics is that the family either gets the tool ahead of the clinic through a MyChart portal to do before the clinic visit, or that the clinical staff, whether it's the clinician or the LVN or the MA, they'll put the screen up on the telehealth screen through a screen share and have the patient look at it, and then have the patient tell them the answers, and then they're entering it into the EMR. I've also heard of some clinics where they're reading the questions to the patients prior to the clinician visit. I hope that answers the question. Yeah, you're welcome. And so one of the ways that we can sustain sort of universal screening is that we make sure that we are getting paid for it. And the amazing thing is that Medicaid is reimbursing clinics who screen. They can get paid for each screen that's completed, and it's $29 per screen. And that those funds can be used by the clinic in order to make sure that we are sustaining our efforts. In order to draw down on the funds, the provider, the NP or the MD, bills for that screen. It has to be entered into the EMR, and then you need to do a bill capture, and I'm going to show you what billing codes to use. In order to bill, that provider needs to self-attest to completing an online training. I'm hoping that all of your providers have done that training, and if not, it's not too late. You can still do it. Again, Marina, I'm going to rely on you to enter the link to the online training so that the providers can attest, so that you guys can start to bill for the screening. And so here are some key requirements for drawing down on payment. The payment started as of last January 2020, which is so exciting. There's no deadline to attest, it's ongoing. And just because the NP or the therapist or the MD needs to attest, anybody can take the online training, and I think it's wonderful, and your entire staff can take it if they want to. So the provider setting and type is that the clinical setting in which billing occurs through Medi-Cal, it's fee for service or from a network provider to a managed care plan. And here are the healthcare common procedural codes. And so there are 2 codes based upon the score. These are G codes. And so if the ACES score is 4 or greater, the G code is G9919. And this indicates that the patient is at high risk for toxic stress, and that education was provided, and that we used evidence-based interventions if necessary. A low risk code, this is if the score is 0 to 3. This is G9920. And this is based upon the original ACES screen for adults, or the original questions, the part 1 questions on the Pearl screen. So who are the qualifying providers? And so the folks that can bill are inclusive of midwives, certified nurse practitioners, licensed social workers, counselors, therapists, clinicians, psychologists. You can see that there's a list here. So I'm going to walk you guys through 2 cases. And so the first case is a 2-year-old that I saw for the well child check, working through this algorithm, and I'll go back to the algorithm. Don't mean to make you guys dizzy. So this is a 2-year-old who we knew ahead of time was coming in for a well child check. And so the patient registered, was roomed by an MA. The MA gave the patient the appropriate screen. And so in this case, it was the Pearl screen for 0 up to the 12th birthday. The family filled it out before I came in the room, and then the paper screen was put on the outside of the door. When I walked up to the room, I grabbed the screen and I saw that the score was a 0. I then went into the room, I did my visit, my well child visit, and based upon the scoring algorithm, the score was a 0. And so I provided education and anticipatory guidance on ACEs, toxic stress, and buffering factors. my anticipatory guidance included the fact that, thank you so much for taking that screen. I wanted to share with you that the relationship that you have with, Jennifer is so important. Jennifer is 2 right now, but all of the time that you guys are spending with one another is really important. And that the more time you can spend with one another, the healthier Jennifer is going to be when she grows up. That what we do know is that stress affects children. It also affects adults, that it can affect children's hearts or minds and their bodies, that stress can get underneath their skin. That we do have a lot of tools and resources in this clinic, and that you're doing a good job. And I just want you to know what a good parent I think that you are. When I said this to this mother who had marked 0 as her score, her response blew me away. Her response was, thank you so much for asking me these questions. I wish that my pediatrician had asked my mom these questions, because if she had, the pediatrician would have found out that every single one of these questions would have been positive. I wish that someone had taken the time to see me and to ask. And I'm so thankful that you asked me about my daughter, and seeing that my daughter score is 0, it does make me feel like a good parent. It makes me feel like I'm doing a good job. Thank you so much. Right. The second case that I want to go over with you is another one of my patients. And the little girl is a 5-year-old who had come in for a school physical. Again, they had registered the MA knowing that they were there for a physical, had given the grandmother, in this case, the screen to fill out and put it on the door. When I walked into the room, well, before I walked in, I grabbed the screen and I saw that the score was a 7. It was a 4 on part 1 and a 3 on part 2. So I go through my physical, and then, I get to my anticipatory guidance, and I ask the grandmother, so how was that for you? Thank you so much for taking the time to fill this out. And the grandmother said, I know what's going on in her life. I've had her since she was just a couple months old, that she is connected to resources. She sees a therapist, and I got this. We got this. I'll let you know if there's anything else that we need. And that was a moment for me when it was reinforced that the only person in that room that didn't know what was going on was me, right? Families know what's going on in their lives. And by not asking the questions, we're doing nobody a service, because families, this grandmother was a hero in the life of her child. She was getting the resources that she needed. And here I am trying to manage this child's asthma. We're talking about school readiness. And by not asking the questions, I would have never known what the stressors were on this child. And it helps to inform me in providing her medical care. And it became so clear that trauma is so ubiquitous. By not asking the questions, it's doing a disservice to me as the medical provider who's working with the family in order to jointly create medical plans. And not knowing is not helping anybody. And so it also was clear to me that this grandmother had it handled, and it is my job to be there as a resource for her if she needs resources and tools. And that knowledge is helping me to make sure that I am the best that I can be for this child, who really is so resilient and surrounded by so much love and so much care. So I have a couple of tips, and this is for everybody who is taking care of patients and helping to make sure that our community is as well as possible. And so if you are a care coordinator or an LVN or registration staff, to really, like, before the clinic session starts, even the day before, to make sure that charts are being scrubbed so that you know who to administer the screen to, right? And then to make sure that you have appropriate copies of the screening tool. Some of the mistakes that we made when we were first starting is that, for instance, an English screen would be given to a Spanish-speaking family. There's no reason for that. The screen is translated into 17 different languages. You just have to make sure that you have copies and that they're labeled appropriately. Or that you give a teen screen to the caregiver of a 7-year-old, right? No reason for that. It's just making sure that you're prepared. After the patient completes the screen, that make sure there's a designated staff member who collects the screen from the family and that the clinician then has a copy of it. And then the action items for those of us that are clinicians are to really practice this anticipatory guidance, to make sure that we are always centered and connecting and collaborating, and to make sure that we have educational material that's available. You know, the response, the plan should be jointly created with families. And the thing is, you do have resources and there are interventions, right? That intervention might be having the conversation. It might be needing to refer the families to the food bank or to green space and local parks or to specialized mental health services. And if that's the case, especially for the unmet basic needs, you really can lean into your care coordinators and the resource database within Find Connect or whatever resource database you guys are going to end up using. We need to make sure that we are documenting the score and the plan in the EMR, and to acknowledge that not everything has to be done at once, right? We are primary care clinics. We have the luxury of being able to follow up with families. And so it might be that the score is a 7 and you don't need to solve everything at once. You can arrange for follow-up to talk about the mental health concerns, to make sure you're following up to talk about the referral to the food bank or to the local parks that you made. So I'm going to stop the slides, and I have 2 questions for us to discuss. The first is sort of, what are you going to take away from this training? And then the second is, based upon those objectives that you saw at the beginning of the presentation, how are you planning on implementing this in your practice?